Hello everyone. Today we are going to discuss a very important topic, that is identification and stabilization of a sick neonate. Why is this important? As we all know that newborn babies, unlike older children and adults, cannot speak, and therefore it becomes the responsibility of caregivers to observe them closely and identify for any signs of sickness before their condition worsens. Also, we know that newborn babies can sometimes deteriorate very rapidly, sometimes even without giving much warning signs. And therefore, it becomes all the more crucial that we keep on closely observing them and identify any signs of sickness and act accordingly. Now, whenever we are assessing a newborn baby, whether it is in the NICU or it is in the emergency room or it is in the labor room, you should do a quick primary survey or assessment, at the end of which you should be able to classify whether the baby is well or whether the baby is showing any signs of sickness or if there is something wrong which requires urgent attention. Now, this primary survey can be done in neonates by assessing the 5 key areas, which can be remembered by using a very simple acronym of STOPS. STOPS stands for S for sensorium, T for temperature, O for oxygenation, P for perfusion, and S for sugars. By quickly going through all these steps, you will be able to identify which area requires urgent attention, and also these 5 areas will cover overall health of the baby. We will go through each of these in the subsequent slides. Now first, let us begin with the first parameter of STOPS, that is sensorium. Now, how do you assess the sensorium of the baby? You assess the sensorium by checking the tone, by checking whether the baby is responsive to sound, to cry, to touch, to handle. How is the baby's cry and how are the baby's spontaneous movements? A red flag here will be if a baby is lethargic, unconscious, or if the baby is having convulsions. Now, look at this video. An active baby will have a normal tone, will be responsive to sound, to touch, to handling. Even during the rounds, if the baby is active and you change the diaper or you touch the baby slightly, an active baby will start moving even though the baby might be sleeping. An active baby will have a good cry and good spontaneous movements, as we just saw in this video. On the contrary, look at this video. Look how the baby is behaving. Here, the baby appears sleepy. Even when the caregiver is touching and handling the baby is not waking up. He is not moving much. There is no cry. The baby is not resisting any movements. And also, the spontaneous movements appear very less. So, a lethargic baby will be floppy, will have poor response to touch and handling, will have a decreased or weak cry, and will have decreased movements, as we saw in this video. In NICU, sometimes it becomes little difficult to differentiate whether the baby is sleepy or whether the baby is having lethargy. So what do? You assess the baby again after some time. Now here let us see the monitoring charts of 2 babies. Here we have baby A and here we have baby B. So baby A and baby B. Now if you look at the monitoring chart of baby A, this baby has a normal sleep-wake cycle. The baby is sleeping, but in between he has cycles. When he's waking up, he's feeding, then again sleeping, then again waking up and crying. So this is very reassuring and it means that the baby is responsive, is neurologically okay, and is having a well-preserved sleep-wake cycle. However, if you look at the monitoring chart of baby B, now this baby has been sleeping continuously for more than 6 hours. Any baby who is sleeping for more than 6 hours or not waking up spontaneously needs attention. This could mean that the baby is having some underlying problem, which could be either a low blood sugar, an involving infection, a low sodium, meningitis, or some form of brain injury. So, any baby in the ICU or any baby who is not waking up spontaneously, you should get alerted. Another important parameter to assess when you are assessing the sensorium is whether the baby is having any abnormal movements. Now look at this baby. Look at this baby. This baby is having abnormal movements. As you can see, the baby is having repetitive, jerky movements of the left upper and lower limbs. These are convulsions. Okay. Now, in newborn babies, sometimes the convulsions may not be as evident as in this video, and therefore you have to be very observant sometimes. They may have some movements like continuous flickering or blinking of eyes, eye staring, deviation of eyeballs, or continuous chewing movements. They may have purposeless movements of the limbs like bicycling or swimming. So, or they may have sometimes apnea. So, all these are forms of subtle seizures which neonates can have. So, you should be very observant for all these abnormal movements and should not miss them. So, having assessed the sensorium, once you have seen that the baby is lethargic or unconscious or is having convulsion, now what is the next step to do? So, if the baby is lethargic, do not wait, you should act fast. Check the blood glucose levels. Hypoglycemia is a very common reason for lethargy in babies. If the baby's sugar is less than 45 mg per deciliter, you give dextrose 10% 2 ml per kg, followed by a dextrose infusion at glucose infusion rate of 6 mg per kg per minute. At the same time, assess other parameters of stops like oxygenation, perfusion, and temperature, and also the sugars. A baby who has been keeping lethargic, particularly for more than 6 hours, may be having problems like a low blood sugar, as discussed, dyselectrolytemia, like a low sodium or a high sodium level, sepsis, NEC, meningitis, or some form of brain injury. If possible, keep on monitoring the baby and reassess after 1 hour. Now, if the baby is having convulsions, you have to act fast, maintain the airway, secure IV access, check blood glucose levels, and if sugars are less than 45 mg per deciliter, give dextrose 10% at 2 ml per kg intravenous, followed by a D10 infusion at glucose infusion rate of 6 mg per kg per minute. Correct hypoglycemia, as we discussed. Check calcium levels also. Hypocalcemia is also a common reason of convulsions in newborn babies. If there is low calcium level, give calcium gluconate 2 ml per kg diluted in same amount of 5% dextrose. Give it over 5 to 10 minutes slowly under cardiac monitoring. If convulsions or seizures are persisting, start injection phenobarbital at 20 mg per kg loading dose diluted with normal saline, again slowly over half an hour. Having assessed the sensorium, the next important parameter to assess in stops is temperature. Now look at this video. Whenever you are assessing the temperature of a newborn baby, use the dorsum or the back of your hand to assess the abdomen and the limbs, as we are seeing in this video. Okay? Yeah. So now the baby's peripheries should be as warm as the abdomen. Use a thermometer to check the axillary temperature. So normal body temperature for a neonate is 36.5 to 37.5 degrees Celsius. So what will be the red flag here? If the baby is having cold peripheries or if the baby has low temperature, that is less than 36 degrees Celsius, this baby needs urgent attention. What will you do? First, remove any wet clothing that might be there on the baby. Keep the room warm, at least 26 degrees, using an external heating device. Cover the baby with 2 layers of cotton clothes. You can use caps, socks, gloves. If mother is here, start skin to skin contact immediately or do kangaroo mother care. If the temperature is particularly below 36 degrees, rewarm the baby actively under radiant warmer in servo control mode. Monitor every half hourly till temperature reaches 36.5 degrees Celsius. This is very important because hypothermia or a low body temperature is very important in predicting outcomes of babies. It has been seen that even a 1 degree drop in temperature of the baby can increase the risk of death by 28%. That is why it is very important that euthermia is maintained in newborn babies. Now, another very important thing which I want to share here is that whenever you are monitoring a baby in the NICU, when the baby is kept under radiant warmer in servo control mode, as you can see here, yeah, so the heater output will be displayed on the display panel. So once the babies are stabilized and like they are stable, most of them will not require a heater output of more than 5 to 25%. However, if a baby is requiring progressively higher heater output, so for example, you saw a baby at 3 p.m., the heater output was 25%, at 6 p.m., it became 50%, after 6 hours, it became 75%. That means this baby is progressively requiring more amount of heat to maintain its body temperature. So this is thermal instability. That means the baby is requiring more heat from outside to keep itself warm. So this could be first sign of infection or sickness in a baby. So you have to be very careful and regularly monitor heater output of babies under the radiant warmer. Thermal instability may be first sign of sickness. If hypothermia is persisting despite of rewarming, then always consider shock or sepsis. Now, we have seen sensorium, we have assessed the temperature. Next important parameter in this STOPS pathway is oxygenation. So when we are assessing the oxygenation of the baby, what do we need to see? We need to see first, is the baby breathing? Second, we need to check the oxygen saturations, attach pulse oximeter immediately, monitor oxygen saturation, and also assess for cyanosis, central cyanosis, that is bluish discoloration of the lips, tongue. Also, third thing we need to see is the degree of respiratory distress the baby is having. So what will be the red flags here? Any baby who is having apnea, gasping, it's an emergency. A baby who is having central cyanosis, an oxygen saturation of less than 90%, a respiratory rate of more than 70 per minute, severe retractions, and a grunting sound. All these means that the baby needs urgent attention. So, what do you do? Yeah. So, there are some videos I will show in which the retractions and grunting part will become more clear.
Infants with acute respiratory
So here
infections
you can see there are retractions.
Infants with acute
Again,
respiratory infections.
you can hear it again. This is grunting. Again, this is a baby having severe sternal introit, severe respiratory distress. There is head bobbing, there is sternal introit, subcostal retractions, and there is seesaw movement. So all these babies require urgent attention and intervention. So this is how you assess the oxygenation. First, look whether the baby is breathing. Attach pulse oximeter, check oxygen levels, SpO2 levels. And third, look for any respiratory distress if it is there. Now, for assessing the respiratory distress in newborn babies, there are few easy scores which can be used, like Downey scores and Silverman-Anderson score. Downey score is usually used in term babies, whereas Silverman score is used in preterm babies. Now, in Downey's score, to assess the degree of respiratory distress, there are 5 parameters which we need to monitor. The first is respiratory rate, second is cyanosis, third, retractions, fourth, grunting, and fifth is air entry. Now, if a baby is having a respiratory rate of less than 60, it is scored as 0, 60 to 80 scored as 1, and more than 80, it is scored as 2. Similarly, if a baby has no cyanosis, it is scored as 0. If there is cyanosis in room air, it is scored as 1. If there is cyanosis with 40% oxygen, then it is scored as score 2. If there are no retractions, it is a score 0. If there are mild retractions, score 1. Moderate to severe retractions, score 2. If there is no grunting, it is score 0. If the grunting is audible only with stethoscope, but it is not audible to bare ears, then it is a score of 1. And if it is audible even without a stethoscope, then it is grade 2. And the fifth one is air entry, which you have to check with a stethoscope. If the air entry is clear, the breath sounds are heard clearly over the both lung fields, then it is 0 score. If the air entry is decreased, then it is score 1. If the air entry is barely audible, that means you cannot hear any breath sounds, then it is score 2. The scores are then added up and a score is given out of 10. So a score of 1 to 3 means the baby is having mild respiratory distress. 4 to 6 means baby is having moderate respiratory distress. And any score 7 or above means that the baby is having impending respiratory failure. Similarly, Silverman-Anderson score is used in preterm babies where the movement of the upper chest, the lower chest retractions, the xiphoid retractions, the dilatation of nares, and grunting, they are observed to finally score the baby, to score the severity of respiratory distress. Now let us see the video of this baby and try to uh, calculate the distress score for this baby. So here the respiratory rate is around 46 per minute, which is a score of 0, less than 60. Cyanosis, the baby has some bluish discoloration of lips, so it is a score of 1. Retractions are moderate, score of 2. Grunting is audible. Even without a stethoscope, you can hear the grunting, so it is a score of 2. Air entry, we cannot assess in the video, but assuming that the air entry is okay, then the score will be 0. So the distress score for this baby is at least 5. Okay? You can see it once more. So respiratory rate is around 46 per minute. That gives a score of 0. Cyanosis, there is some cyanosis in room air, so it is a score of 1 at least. There are retractions which are moderate, score of 2. Grunting, which is audible to the ears, so it is 2. Air entry, which we are not sure, but suppose the resident tells that the air entry is okay, then it is a score 0. So distress score at least is 5 in this baby. Now, we have assessed the baby's oxygenation and respiratory status. So what actions do we take next? Now, if the baby is not breathing, is having apnea, or if the baby is gasping, maintain the airway by positioning the head correctly. Place shoulder roll immediately. Suction the mouth and nose if there are visible secretions. Stimulate the baby to breathe and administer positive pressure ventilation with bag and mask. If the baby's oxygen saturation is less than 91%, provide oxygen using either a hood box or nasal prongs. Target oxygen saturation of 91 to 95% on oxygen support. Avoid hyperoxygenation as it can be harmful, especially in preterm babies. So now if a baby has too much of fast breathing, that is baby has tachypnea, there are severe retractions, baby is making a grunting sound, the distress score is more than 3, that means this baby is having difficulty in breathing. Here we need to monitor the baby closely. If these signs are persisting, then probably this baby will need CPAP support. So in this case, start CPAP support around 5 to 6 centimeter of H2O. Use FiO2 of 30% initially and then titrate the CPAP according to breathing effort and the SpO2 levels. Again, as discussed previously, use a target saturation of keep a target SpO2 of 91 to 95% and keep monitoring the baby for worsening or improvement. Now we have assessed the sensorium, the temperature, the oxygenation part of STOPS pathway. Now, next important parameter in the STOPS pathway is perfusion. So what is perfusion? It is basically how well the blood is flowing in all organs of the body. And how do we assess the perfusion of the baby? We assess by assessing the capillary refill time, checking the heart rates of the baby, checking the pulse volume by feeling the radial pulse or the brachial pulse, checking non-invasive blood pressure, monitoring the urine output, and also by looking at signs of end organ involvement like feed intolerance or poor activity. So, what is the red flag here? Any baby who is having persistently cold peripheries, a capillary refill time which is more than 3 seconds, tachycardia or heart rate which is more than 160 per minute, in absence of fever or any pain, if there are weak and feeble pulses, a low NIBP, and a decreasing urine output. So, all these are red flags, and this baby will need urgent attention. Excuse me. Yeah, okay. So, we will now see how we monitor the capillary refill time. Look at this video carefully.
Capillary refill time is measured by
How do we do?
pressure on
We
the sternum.
press the sternum. See it again. We press over the sternum
Capillary refill time is
for
measured by
5 seconds. We can calculate 5 seconds by counting 1001, 1002, 1003, 1004, 1005, and then see the time which it takes. When we press for 5 seconds, there will be blanching, and the time it takes for the blanched skin to return to pink will give an idea about the capillary fill time. That time should be less than 3 seconds. See it again.
Full time is measured by 5 seconds of pressure on the sternum. Here, this is normal at around 2 seconds.
Yeah. So this is how you measure the capillary refill time. Press for 5 seconds and then see how quickly the blanching disappears back to pink. Okay. For measuring heart rates, you can use pulse oximeter, the multipara monitor, and for measuring blood pressure, there are cuffs which are available especially for neonates, which can be used for monitoring blood pressure in newborn babies. Now, once we have assessed the capillary refill time, the heart rate, the BP, the urine output, the the urine output and the signs of end organ involvement, what action should we take? So, any baby who is having cold peripheries, a CFT of more than 3 seconds, a heart rate of more than 160 per minute, may be having abnormal perfusion or shock. In such cases, give normal saline 10 ml per kg over 30 minutes. This is important because in older children and adults, we usually give bolus over a shorter duration. But however, in newborn babies, we usually give bolus over 30 minutes. is little slower than their older children. After that, we have to reassess, keep monitoring the CFT and the heart rate and the blood pressure once you are giving some intervention for abnormal perfusion. Even after the saline bolus, if the CFT stays more or if the heart rates are not settling, then you may need to initiate inotrope like dopamine at 10 microgram per kg per minute if the neonate remains in shock despite fluid status, fluid bolus. Now again here, look at the monitoring chart of this baby. This baby was having a CFT of around 2 seconds at 11 a.m. Heart rate was 148. Slowly, as you can see here, at 12 the CFT increased to 3 seconds and heart rate became 156 per minute. Again at 1 p.m. the heart rates have started increasing, and at around 2 p.m. the CFT is 4 now and heart rate is 178 per minute. Baby is having cold peripheries. Now what action has been taken? A bolus of 10 ml per kg has been given, and over the next half to 1 hour the baby's status has started stabilizing. So by measuring such simple CFT and heart rate, timely action could be taken to prevent further worsening of the baby's condition. Remember, you don't have to wait for the BP to fall. Fall of blood pressure or hypotension is a late sign. We should be able to pick up abnormal perfusion at this stage itself. Now, the last parameter, but one of the most important parameters in the STOPS pathway is sugar, that is blood glucose levels. Whenever you have a sick baby, in NICU or in ER or anywhere, you have to check the blood glucose levels. So check RBS in all symptomatic babies, sick neonates, and also in certain high risk neonates. Like suppose there is an infant of diabetic mother or a baby who is late preterm, that is, the baby is born between 34 to 36 weeks of gestation age, or if it is a small for gestation age baby, or if it is large for gestation age baby. In all these conditions, you must monitor blood glucose levels. Also remember that both hypoglycemia as well as hyperglycemia can result in brain damage. So it is important to understand that not only hypoglycemia is problematic, but if a baby who has been doing otherwise well and he starts showing hyperglycemia, that means that the baby could have been in stress. It can be a sign of underlying infection also. So what will be the red flag here? Any sugar value less than 45 mg per deciliter or more than 125 mg per deciliter, you have to act. Now, once the baby is having a low blood sugar, you need to see how low it is and whether there are any symptoms. Symptoms of hypoglycemia can sometimes be very non-specific. The baby may be jittery, the baby may be dull, he may be lethargic, or they can be more serious, like the baby might start having seizures. Sometimes the babies might have just tachypnea or tachycardia. If the baby is having symptoms and if the sugar levels are less than 45 mg per deciliter, give 10% dextrose bolus at 2 ml per kg slowly over 1 minute. Start glucose infusion rate at 6 mg per kg per minute. The fluid is calculated as shown in this formula. Glucose infusion rate is equal to fluid in ml per kg per day in into dextrose concentration divided by 144. Now, for a ready reckoner, around 86 ml per kg per day of 10% dextrose will give a GIR of around 6 mg per kg per minute. So, this you should always remember. So, for example, for a 2 kg baby, 86 into 2 is 172 ml per day, that is around 7.1 ml per hour of dextrose 10% will provide a GIR of 6 mg per kg per minute. Now, if the baby is asymptomatic, then a trial of feeds can be given and IV fluids can be started if the baby is not improving or if the sugars are remaining below the threshold levels despite of feeds. Now, we have discussed the primary assessment pathway of STOPS, which includes the assessment of sensorium, temperature, oxygenation, perfusion, and sugars. Now, there are certain conditions where you may not have time to do a primary survey, and these conditions are life threatening, and the baby can go into cardiac arrest if action is not taken immediately. So, these are apnea, where you have to immediately place the baby under warmer, stimulate, suction, position the baby, administer positive pressure ventilation if required, even before stepping to do the primary survey. Next is if there is any bleeding. For a bleeding neonate, especially if it is severe bleeding, you need to quickly secure an IV access, take samples for cross matching, request for a PRBC transfusion, also give vitamin K immediately. And while the blood is being arranged, you can give normal saline bolus so that the baby does not develop shock. Next is convulsions. As we have seen, a baby who is having convulsions should be attended immediately, and we have already discussed the line of action. So apnea, bleeding, convulsions, these are all pre-arrest conditions. Here we do not have time to do the primary survey and we must act immediately. Now, this is again something which is very important. Many of us who are working in level 1 or level 2 units, where we don't admit sick babies routinely, it is very important to identify which babies will need referral to higher center. It is important to do so that the babies are transported and referred early so that their outcomes will be better. If the babies are not transported timely to a certain center which can provide a better level of care, then the outcomes may not be so good. That is why it is always very important to understand that when should you refer the baby in case you are not seeing very sick babies regularly. So any baby who is having persistent lethargy, whose hypothermia is persisting in spite of rewarming, if there is FiO2 of more than 30% and CPAP is more than 6 centimeter of H2O, if there is abnormal perfusion which requires inotropes, if there is symptomatic hypoglycemia, a bleeding neonate, any neonate who is having jaundice with encephalopathy, these babies should be referred possibly to a level 3 care. Always remember that before referral and transport, give the pre-referral dose of antibiotics and stabilize the baby before transporting. So let's do a quick recap of what we have learned so far. For doing a primary survey of the baby and identification of signs of sickness, use the STOPS acronym, which stands for sensorium, temperature, oxygenation, perfusion, and sugars. Now let us quickly see an example and see how we can apply this acronym. So here is a 7 days old baby girl with birth weight 3 kg who is brought with inability to breastfeed to the ER. Now the nurse quickly does the assessment using the STOPS pathway. So the sensorium assessment is the baby is lethargic. The baby has not fed in last 8 hours. So what will be the action as discussed? This baby immediately check RBS. RBS is 38, which is low. Give dextrose 10%, 6 ml stat followed by D10 infusion at 10.7 ml per hour and simultaneously assess other parameters of stops. Now temperature, the baby is having a temperature of 36 degrees Celsius. The baby is hypothermic. So do active rewarming in radiant warmer. The oxygenation baby is breathing well. SpO2 is 89% on room air. Respiratory rate is 64 per minute. There are no retractions or grunting. This is a mistake. I have written retractions, grunting. There are no retractions and no grunting. So administer oxygen. Perfusion, CFT is 4 seconds. Heart rate 178 per minute. Mean blood pressure 30 mmHg. That means the perfusion is compromised, baby is having a prolonged CFT, there is tachycardia, blood pressure is low. What will be the action? Give normal saline at 10 ml per kg over 30 minutes, reassess after half an hour. Sugar, as we have already discussed, is 38. We have given dextrose 10%, 6 ml start, followed by D10 infusion at 10.7 ml per hour. So by using a simple STOPS acronym, we have been able to identify which are the problem areas which need to be attended first. And we have been able to stabilize the baby. So thank you everyone for your attention, and I really hope that all of you start using stops wherever you see a baby, whether it is in the ER or in the labor room, or even when you are doing daily rounds in the NICU. Try to use these stops and try to assess the newborn babies using this pathway. Thank you very much once again.